Good morning, everyone. Uh, COPD is the commonest respiratory disease, and I'm sure you all are managing COPD patients in your clinic very well. And COPD is a vast topic too, so it's not possible to cover it in 15 or 20 minutes. But still, I will try to touch upon the recent advances and recent updations which are covered in GOLD guideline. So what is GOLD? It is an annual evidence-based COPD strategical document which is published by an organization called Global Initiative for Chronic Obstructive Lung Disease. And its purpose for updation is to incorporate latest evidence to optimize diagnosis, treatment, prevention, and monitoring of COPD. This is the definition of GOLD COPD. Little bit of complex, but it involves the symptoms. It also mentions that abnormal structure and impaired function of lung. Why it is called global health crisis? Because COPD is the third leading cause of mortality worldwide, and nearly 90% of the COPD deaths are occurring in low and middle income countries. It is estimated that 213 million people worldwide were living with COPD in 2021, and 30 to 40% of COPD patients worldwide are never smokers. The important slide which is included in this recent 2026 COPD guideline is the FEV1 trajectories over the life course. So normal trajectory, what is the normal trajectory? Is that basically lung કેવી રીતે grow થાય છે. For initial 20 to 25 years is the developing phase કે જેમાં lung ધીમે ધીમે grow થતું હોય. Then the individual attains its maximum capacity near about 25 years of age. Then comes the plateau phase of when the person is of 25 to 30 years of age. At that time, the lung function remains at its peak, and then there is a normal decline in lung function every year after the age of 30 years. So that is the normal lung trajectory. But in COPD patients, there are the two commonest trajectories which is commonly observed. The first one is કે ઘણી વખત because of poor development of the child, maternal smoking, maternal smoking as well as poor nutrition and exposure to environmental tobacco smoke and parental smoking, the lung growth does not happen which it's supposed to be. So it does not attain the maximum growth which it's supposed to do, and then it declines at normal pace. And the other trajectory is that કે lung growth in a normal phase માં જ થશે, પણ it declines very rapidly because of the smoking and other occupational exposure of dust particles. So what is the clinical implications of these lung trajectories? So understanding of these trajectories will help in detection of at-risk individuals early and to target them in childhood and adolescence, to emphasize smoking cessation and exposure reduction program, and to prevent acceleration of FEV1 decline. This is the very nice study, and it has very nicely mentioned that early diagnosis of COPD will help significantly to preserve lung function, to significantly decrease lung function decline, and to significantly improve the symptoms in COPD patients if they are diagnosed very early. So for the earlier diagnosis of COPD, certain new terms has also been introduced by GOLD, that is early COPD, young COPD. Early COPD are the patients who are having this disease in biologically early stage, and we find out it near the beginning of the process. And young COPD patients are usually 20 to 50 years of age, who are having structural and functional abnormalities, and they have never achieved their normal peak function, peak lung function. They have either shorter plateau phase or early lung declining phase, and usually they are misdiagnosed and undiagnosed and untreated. Another terms which is suggested by this gold guideline is the pre-COPD. The pre-COPD patients are having respiratory symptoms. They also have exposure to risk factors, and also, but they are having that post-bronchodilator spirometry where the ratio of FEV1 by FVC is more than 70%. And they have detectable presence of structural and functional abnormalities. So these are the patients where they may or may not develop COPD over the period of time, and they can be of any age. Another term which is suggested is PRISM, that is preserved ratio and impaired spirometry. These are the patients who have preserved ratio of FEV1 by FVC more than 70%, but they have post-bronchodilator FEV1 and or FVC less than 80% of the predicted. And 40 to 50% of this patient has chances of developing COPD over the next 5 years of timeline. And they are at increased risk of all-cause mortality, especially cardiovascular. So the environmental factors other than tobacco smoking that can start early in life and in young individuals, and they are the precursor for pre-COPD and PRISM, and which opens new window to identify that patient, opens the new window and opportunity to prevent the disease earlier, to diagnose this disease earlier, and to get patient a better relief. The newer concept which is introduced in this recent guideline is dysbiosis. What is dysbiosis? It is an altered airway microbe in COPD. Basically, normal bacterial commensal flora remains inside the lung, but over the period of time, because of smoking and air pollution, impaired mucociliary clearance, and impaired immune host immunity, the bacterial flora gets changed to the pathogenic microbiome, and this pathogenic organism will stimulate the innate immune system. It will increase the cytokine, so it leads to sustained inflammation, and this inflammation leads to tissue injury and remodeling. So it will act as a chronic inflammatory driver. To identify the patient based on its etiotype. Etiotype means to classify the disease based on its etiology is also important. The newer guideline has classified these COPD patients into different etiotypes, like genetically determined COPD, COPD due to abnormal lung development, environmental COPD because of cigarette smoking and because of biomass and pollution exposure, COPD due to infections, COPD and asthma, and COPD due to unknown causes. To identify these etiotypes is helpful to tailor-made the etiology-focused treatment offering to the patient, and it will help in further research, prevention, and personalized care. So coming to the diagnosis of the COPD, all the patients who are having respiratory symptoms like shortness of breath, chronic cough, sputum, wheezing, these all are these patients plus having the risk factors like environmental tobacco smoke, active smoking, occupational exposure to dust, indoor and outdoor air pollutions. These all are patients should underwent the spirometry. Spirometry is mandatory in all the patients, and it should have post-bronchodilator FEV1 by FVC ratio less than 0.7. So this is the diagnostic criteria for the COPD. Now, not coming to the spirometry. Spirometry has already been very well covered by Devkar sir. And the other update, which is included in recent gold guideline, is the classification. The older classification of A, B, C, D has been changed to now only 3 groups, group A, B, and E. So in assessment, first we have to do a spirometry, and spirometry should have FEV1 by FVC ratio less than 0.7%. And in those patients, confirmed diagnosis of this COPD patient, we have to do that airflow obstruction assessment, and that is been done by FEV1 only. If FEV1 is more than 80%, then it is classified as a gold 1. Gold 2 is having FEV1 50 to 80, gold 3 30 to 50, and gold 4 less than 30%. Then after this spirometric assessment, we have to assess patient's symptoms and exacerbation risk. The patient's symptoms is been assessed with modified MRC score and CAT score, and patient's exacerbation in last 1 year. So if the patient's assessment score is low, MRC score 0 to 1 with CAT score less than 10 and no exacerbation, then it comes under category of 1. If patient's symptoms are on higher side, MRC grade more than or equal to 2 with CAT score more than or equal to 10 and no exacerbation in previous year, then it comes under category B. And any patient who are having even a moderate exacerbation, single moderate exacerbation in a year, then also it is considered in category E. And this treatment escalation considered after any moderate exacerbation. So what is the goal of stable COPD? Treatment of stable COPD. The goal of treatment of COPD is to reduce symptoms and to reduce the risk. So this is the very nice diagram showing the recommended treatment as per the GOLD guideline. For the group A patients, short-acting bronchodilator is recommended. For group B patients, long-acting beta-2 agonist with long-acting anti-muscarinic agent is recommended. And in group E patient, again, LABA plus LAMA is recommended. We can consider adding inhaled corticosteroid for those patients who are having blood eosinophil count more than 300. And when this patient comes to the follow-up, if the patient is doing well, then we need to continue with the same medications. If the patient is having persistent dyspnea, then we can add LAMA with LAMA. And still, if the patient is having dyspnea, then we have to see other things also, whether the patient is taking medicine regularly or not, whether the inhaler technique is proper or not. We have to look for the other causes of dyspnea if the patient is having it. And if the patient is having more than one exacerbation, then we can see blood eosinophil count, and if eosinophil count is more than 300, we can add LABA, LAMA, and ICS. And we can offer other treatment like roflumilast, azithromycin, and other biologics also. Now, factors to consider when considering inhaled corticosteroid in COPD patient. Inhaled corticosteroid patient is strongly recommended in COPD patients who are having blood eosinophil more than 300, who are having history of concomitant asthma, who are having more than 2 exacerbations per year, and who are having a history of hospitalization for the COPD exacerbations. We can still favor use of corticosteroid if the patient is having 1 moderate exacerbation per year and blood eosinophil count is more than 100. And guideline strictly against the use of corticosteroid in those patients who are having blood eosinophils less than 100, who are having history of mycobacterial infections, and who are having repeated lower respiratory tract infections. So these are the treatment which we discussed for the patient who are presented for the first time. Now suppose who are the patient who are coming to us and the patient is having patient is taking LABA plus ICS regularly. ઘણી વખત બહારથી પેશન્ટ આવતું હોય, ઓલરેડી ફોરાકોવટ એરોકોવટ ચાલુ જ હોય, તો એ પેશન્ટમાં શું કરવું? So for that they have mentioned that if the patient is not having any current exacerbation and patient has previous positive treatment response with the same treatment, then we can continue the treatment in low symptom load patients. If the patient is having higher symptoms, then we can consider adding LAMA along with LABA and ICS. If patient is not having any relevant exacerbation history, then we can consider changing LABA with LAMA instead of inhaled corticosteroids. And if the patient is having current exacerbation with higher eosinophil count, we can add LAMA along with LABA and ICS. So this is the very nice diagram which includes all the management of COPD in one slide. Now coming to newer advances. ensifentrine. It is a novel first-in-class dual inhibitor of phosphodiesterase 3 and phosphodiesterase 5, and it acts via three key mechanisms. It acts on smooth airway muscles for the bronchodilation. It also has an anti-inflammatory effect, and it also improves mucociliary clearance. GOLD guideline clearly states that ensifentrine significantly improves lung function, dyspnea, and health status. So it is recommended by GOLD. It is still not available in India. And the other one is biologics, dupilumab. The dupilumab is a monoclonal antibody which works by targeting interleukin-4 receptor alpha subunit, and it acts by interrupting signals which causes an inflammation. Guideline recommends that dupilumab reduces the exacerbation, improves his lung function and quality of life in patients with moderate to severe COPD, history of exacerbations, chronic bronchitis, and eosinophil count more than 300. So where does GOLD guidelines stay about this? It has clearly mentioned that in the patient having persistent dyspnea, then for the add-on treatment, we can consider adding ensifentrine. And for the patient who are having moderate to severe exacerbations and higher blood eosinophil count and concomitant asthma, we can give trial of biologic therapy like dupilumab or mepolizumab. Another concept which has been introduced is to categorize the patient based on phenotypes. And each phenotype offers new treatment or we can say add-on treatment for the patient who are not just managed with LABA and LAMA. Multimodality concept is also introduced in this GOLD guideline. The patients with COPD are having cardiovascular disease, metabolic disease, anxiety and depression, and other respiratory diseases also, because they are sharing common risk factors. So management includes integrated care and co-speciality collaboration. So basically GOLD એવું કહેવા માગે છે કે COPD ને આપણે ખાલી જસ્ટ એક ડિસીઝ તરીકે ના જોઈએ, કે COPD ને ખાલી જસ્ટ COPD with comorbidity તરીકે ના જોઈએ, but it is a multimorbid state with co-occurring disease. And the important other aspect which has been touched upon in recent guideline is artificial intelligence and emerging technologies. Though we are in very early phase, but artificial intelligence can help in diagnosis, risk prediction, and monitoring. But these are the tools to support the clinical decision. It cannot replace the clinical decision. Another thing which has been introduced in recent guideline is climate change and COPD. The recent climate change with increased outdoor temperature and heat waves, it also disrupts the ground level ozone level, and wildfire that also increases the noxious particles and increase the chances of developing a COPD. It has been observed that higher outdoor temperatures were shown to be linked with an increased risk of hospitalization, and lower temperatures were linked with increased risk of exacerbation. Now coming to the non-pharmacological treatment of COPD. Again, each of these points has a separate topic and we can discuss individually in a thoroughly manner, but the time does not permit. And the most important thing is smoking cessation. Smoking cessation is the only intervention which alters the natural history of patient in COPD and which improves the long-term survival. So guideline recommends that it should be recommended in all the patients of the COPD. We can offer pharmacotherapy as well as behavioral interventions. Pharmacotherapy in the form of nicotine replacement like nicotine patch, gum, lozenges and inhaler. And we can also offer bupropion sustained release tablet as well as varenicline. The another thing is pulmonary rehabilitation. Pulmonary rehabilitation is a comprehensive intervention for the patient-tailored therapy which involves exercise training, education, self-management intervention for the improvement in physical and psychological condition of the patient. It is usually a 2-hour session done twice a week, at least for 6 weeks. Initially, it should be done supervised. Later on, patient do it by himself only. There are certain trainings which can be teached to the patient, like endurance training, interval training, resistance and strength training, upper and lower limb exercise, and inspiratory muscle training. So these are the benefits of pulmonary rehabilitation. It reduces the breathlessness, increases muscle strength, increases stamina, improves mood and well-being. Another important thing which is stressed in this newer gold guideline is the vaccination. Pneumococcal vaccination is to be given in all the patients more than 50 years of age, and if the patient's age is between 19 to 49, along with other serious lung condition, then can also be pneumococcal vaccination can be given. Either pneumococcal conjugate 13-valent or 15-valent vaccine, followed by next year pneumococcal polysaccharide vaccine 23-valent, or single dose of pneumococcal conjugate vaccine 20 unit, or pneumococcal conjugate vaccine 21-valent vaccine. Another is influenza vaccine. It should be given to all the patients of the COPD every year intramuscularly. Then respiratory syncytial viral vaccine is also advised by COPD. It is a single intramuscular dose for the patients having more than 50 years of age, but it is still not available in India. Zoster vaccine is also advised by COPD to protect the COPD patients against shingles. It is a 2-dose vaccine, 0.5 milligram, given intramuscularly and 2 to 6 months apart. Tdap vaccine to prevent against pertussis along with tetanus and diphtheria is also advised by COPD, this gold COPD guideline. Another thing, oxygen therapy. Oxygen therapy is helpful in acute exacerbation as well as for long-term oxygen therapy. Acute exacerbation we have to give in controlled manner to prevent oxygen-induced hypercapnia, and long-term oxygen therapy is advised in severe hypoxic patient. NIV is also required during acute exacerbation for those patients who are having hypercapnic respiratory failure, and long-term NIV can be required in selected cases of chronic hypercapnia. Nutritional support is very important because there is a high prevalence of malnutrition and muscle wasting in this COPD patient. The calorie requirement is 30 to 35 kilocalorie per kilogram per day, and protein 1.2 to 1.5 kilogram per day. Basically, they require a high fat, low carbohydrate, and high protein diet. Another important thing is to reduce the risk factor. For that, we can implement efficient ventilations in home, particularly in kitchen, to use non-polluting cooking stoves, and to avoid continuous exposure to potential irritants, particularly in occupational settings. Patient education is again an important thing. Another thing is surgical therapy. Interventional therapy which is offered in selected COPD patients are lung volume reduction surgery, bronchoscopic lung volume reduction surgery, bullectomy, lung transplant, and tracheal procedures. So my key take-home message is earlier diagnosis is the most important in COPD. Etiotypic, phenotypic, and endotypic classification is helpful for the personalized care of COPD. Blood eosinophil count is now a part of initial assessment of COPD. Even a single exacerbation now influences the treatment escalation decision. Non-pharmacological care and vaccination remains critical pillars. Novel pharmacotherapies are promising. Moving from treatment-oriented approach to prevention-oriented approach is now in focus, and multimodality and AI are growing areas with practical implications. Thank you.